Welcome. Today we're focusing on a serious and often overlooked complication of HIV-associated pulmonary hypertension, or AVAP. We'll explore what it is, how it develops, and what can be done to manage it. Understanding HAPAP is crucial for improving the lives of those living with HIV. The exact cause of HAVAPH remains a topic of ongoing research. It's a complex interplay of factors, not simply a direct result of the HIV virus itself. Several theories exist. One involves the virus directly infecting the cells lining the pulmonary arteries, leading to inflammation and remodeling. Another suggests that HIV proteins might trigger an abnormal immune response, damaging the pulmonary vessels. Co-infections, such as with certain herpes viruses, and genetic predispositions, may also play a role in increasing the risk. Ultimately, it's likely a combination of these and potentially other unidentified factors that contribute to the development of HIV-PH. HIV-APH is characterized by a progressive increase in pressure within the pulmonary arteries, the blood vessels that carry blood from the heart to the lungs. This increased pressure puts a strain on the right side of the heart, which has to work harder to pump blood through the constricted vessels. Over time, this can lead to right ventricular hypertrophy, or enlargement of the right ventricle, and eventually right heart failure. The pulmonary arteries themselves undergo significant changes, including thickening of the vessel walls, inflammation, and the formation of blood clots in situ, further restricting blood flow and escalating the pressure. This reduced blood flow impairs oxygen exchange in the lungs, leading to shortness of breath and other debilitating symptoms. While HIV infection itself is a global pandemic, AVAPH represents a smaller, but significant subset of pulmonary hypertension cases. The prevalence of pulmonary hypertension among individuals with HIV is estimated to be higher than in the general population, though precise figures vary depending on the study and population examined. Early studies suggested prevalence rates as high as 0.5% in HIV-infected individuals, far greater than the rate for idiopathic pulmonary arterial hypertension. With improved AV treatments and longer lifespans, we are starting to see the proportion shift slightly. Further research is necessary to accurately determine the current global burden of HAPA and understand the factors that influence its development in different populations. The symptoms of HIV-APH can be subtle and often mimic those of other conditions, leading to delayed diagnosis. The most common symptom is shortness of breath, especially during physical activity. Other symptoms may include fatigue, chest pain, dizziness or lightheadedness, swelling in the ankles and legs, and a bluish tint to the skin or lips, known as cyanosis. It's important to remember that these symptoms can also be associated with other complications of HIV or opportunistic infections, so a thorough medical evaluation is crucial if you're living with HIV and experiencing these symptoms. Diagnosing HIV-APH requires a combination of tests. The process typically begins with a physical examination and a review of the patient's medical history. Initial screening tests often include an echocardiogram, which uses sound waves to create an image of the heart and estimate the pulmonary artery pressure. If the echocardiogram suggests pulmonary hypertension, a right heart catheterization is necessary to confirm the diagnosis and assess the severity of the condition. This invasive procedure involves inserting a catheter into a vein and guiding it into the pulmonary artery to directly measure the pressure. Other tests, such as pulmonary function tests, blood tests to rule out other causes of pulmonary hypertension, and a ventilation perfusion scan of the lungs might also be performed to gain a comprehensive understanding of the patient's condition. While pulmonary hypertension is broadly classified, APH falls within Group 1 of the World Health Organization, a WHO classification of pulmonary hypertension which includes pulmonary arterial hypertension (PR). Specifically, it's classified as PH associated with HIV infection. It's important to note this classification because it helps guide treatment decisions and allows for comparisons between HIV, APH, and other forms of PH. The treatment of HIV-APH aims to improve symptoms, slow disease progression, and improve quality of life. Management typically involves a multidisciplinary approach, including a cardiologist, pulmonologist, and infectious disease specialist. Treatment strategies include first, addressing the underlying HIV infection with antiretroviral therapy, which is crucial for managing the overall health of the patient. Second, utilizing pulmonary hypertension-specific medications such as phosphodiesterase 5 inhibitors, endothelin receptor antagonists, and prostacyclin analogs, which help to dilate the pulmonary arteries and reduce pressure. Third, providing supportive care such as oxygen therapy, diuretics to reduce fluid buildup, and anticoagulants to prevent blood clots. In severe cases, lung transplantation may be considered as a last resort. While there's no guaranteed way to prevent HIV-APH, several strategies can help reduce the risk. Primarily, adherence to antiretroviral therapy is paramount in controlling the HIV virus and minimizing its potential impact on the pulmonary arteries. Regular monitoring of pulmonary artery pressure, especially in individuals with risk factors for HAPH, can help detect the condition early when treatment is most effective. Avoiding smoking and other lung irritants is also crucial for maintaining healthy lungs and reducing the risk of pulmonary hypertension. The prognosis of HIV-APH can vary depending on the severity of the disease, the response to treatment, and the overall health of the individual. Historically, HIV-APH was associated with a poorer prognosis compared to other forms of pulmonary arterial hypertension. However, with advances in HIV treatment and pulmonary hypertension-specific therapies, the outlook has improved. Recent research is focusing on identifying biomarkers that can predict the development and progression of HIV-APH, as well as exploring novel therapeutic targets. Studies are also investigating the role of inflammation and immune dysregulation in the pathogenesis of HIV-APH, with the goal of developing more targeted and effective treatments.